Hello, everyone. Good morning. Good to see everyone. This feels like the emergency management family reunion for me, so it's nice to see so many of you. As some of you may know, my name is Nicolette Lewis-Saint. I am very pleased to be here with you. I'm very pleased to be with you all on this panel. And I know we have a limited amount of time to tackle a pretty big subject, so we're going to dive right in. I am going to just start with some introductions, and I'm going to allow you all to introduce yourselves. But as you introduce yourselves, I'd ask that you share a memory from the past 3 years that demonstrates the importance of public-private partnerships. So let's start with you, Chris.
You may have to share a mic. All right, I'll save and keep the introduction short since you've heard quite a bit from me already. Maybe I can just kind of jump into my memory from the past 3 years. I mentioned during the course of the EOC tour that one of CDC's really big functions that we focus on is information management. A lot of that also involves relationship management so that information can flow readily. Thinking back to the start of the pandemic, we had a lot of questions coming in about how to protect workers across various sectors, and really having those relationships in place, I think, before the pandemic happened was critical for us because it allowed us to reach out really readily to, for example, the food supply chain, the meat packing industry, a variety of other industries that were really heavily affected by COVID-19 cases early in the pandemic, and work closely with those partners as we developed public health guidance and kind of try to ascertain what was going on in those various types of facilities. Knowing those partners up front made sure that having to reach out when the pandemic was going on was not the first time those connections were happening, so knowing who to call, I think, was really critical in that point. The same thing kind of happened across the medical waste industry as we began having to figure out how to make sure that hospitals could continue to move waste from taking care of patients and do so in a way that was safe and protective of public health. So really, again, kind of underscore the importance of us being able to know who to call, and likewise for our partners being able to know who within the agency to call when something happens. So that'll be it for me.
Hi, everyone. My name is Tom Cotter. I'm the executive director of Healthcare Ready. And before I introduce myself, I just want to say you've been working on COVID so long, it's all over your tie.
It is.
And that is fantastic. Healthcare Ready is a nonprofit organization that sits at the intersection of public, private, and nonprofit supply chain, which we all view through the lens of health equity. I'm relatively new in my tenure there, but I'm really excited about our work. During COVID, we provided a lot of platforms for enhanced collaboration and coordination among public and private partners. My former position has a really interesting public-private story, which is my former organization before Healthcare Ready has an office in Wuhan, China. So it was a global health entity, and so we got very popular very quickly. And we were actually asked by the U.S. government to fill the belly of the planes that were evacuating U.S. citizens from China. And so we went around the country basically and found private sector partners that had privately held PPE and was able to fill the bellies on the evacuation planes. And the goal, of course, was to slow the spread of COVID-19, especially among the healthcare workers that were working in Wuhan on the patients. And there were just so many questions at that point, and recognizing every day we bought was a day that the science could catch up to what we needed to know. So thank you. Really glad to be here.
David?
Hi, everyone. I'm David Senior. I'm the Senior Vice President of AmerisourceBergen. For those of you who don't know who AmerisourceBergen is, we are one of the largest pharmaceutical distributors in the U.S. and actually now the world. We made a large acquisition across Europe about a year ago. We distribute to hospitals, pharmacies, physicians, and obviously played a major role in the COVID response. I've had a variety of roles at AmerisourceBergen in over 22 years. I was the Chief Strategy Officer, CFO of our distribution business before taking on the role I have now, where I get involved in a lot of different projects. And one of my main focus areas is supply chain resilience as it pertains to the health of the pharmaceutical supply chain. My memory, actually, I'm going to go back. It's literally almost exactly 3 years ago. I was giving a presentation to a group of government officials about pharmaceuticals and the supply chain and what's taking place, and some of the things we have to focus on are drug shortages, price volatility, and quality risks of products coming from different places. And the question I got at the end of the session was, that's all really interesting, but what if this trade war escalates and China shuts down exports to the U.S.? I had no good answer to that question, and I don't think anybody would have at that time. But we went back and as an organization and started thinking about the fragility of the supply chain and what could be done. And what we started recognizing was this was too big for one company or even industry to solve on its own, and that was sort of our jump-off point to thinking about public-private partnerships, and started accelerating conversations we had with government officials, whether it was the Strategic National Stockpile, Congress, and others, about what could be done to address what at that time we viewed as supply disruption, not demand surge, and put us fortunately in a really interesting spot when March 2020 came, and we were already in conversations about different ideas that ultimately were useful during the COVID crisis moment.
Richard?
Thanks. Hi, I'm Richard Hughes. I'm a partner at Epstein, Becker & Green. I'm a lawyer. I advise companies across the health sector on a broad range of legal and policy issues. During the pandemic, I was the vice president of public policy at Moderna, and before that, led the vaccines team at Avalere Health. And so I was thinking about vaccine access for a long time before the pandemic, and I was acutely aware of the challenges that we would have if we ever tried to go out and vaccinate every single American. So we were really good before the pandemic at vaccinating children. We had a really strong public-private system for doing that. We had strong coverage and access in pediatric offices. But for adults, vaccine coverage and access was much more fragmented. And that was something that I spent a lot of time thinking about prior to the pandemic and trying to really fix. When you think about the low-income population between the ages of 18 to 64, when you think about seniors and Medicare, there are serious barriers to access for vaccines. We only really ever stockpile on a limited basis for very targeted responses, and we didn't have a bunch of COVID vaccines in the national stockpile, right? So I remember when the pandemic hit, I was helping several companies try to understand how is the government going to purchase and distribute and make these vaccines accessible. And then I went to Moderna, and I remember the moment reading the draft language of the EUA letter where we were about to turn over all of the product to the U.S. government for distribution. And I remember thinking, how is this actually going to get in the arms of every single person who needs it? And I felt incredibly privileged when I was able to actually fly to Boston the end of December 2020 and drove out to the Norwood plant and got my vaccine at our plant. And it gave me a lot of hope that we would be able to reach people where I'm from in the Arkansas Delta, people who really need access to the vaccine and would have a hard time getting it. So it gave me a lot of hope. But, as I'll probably touch on in a moment, I think we still have a lot of fragmentation that we need to address. Thank you.
So this is a perfect cue for the first question for you all. And I know it is difficult to have a conversation like this without dealing with the fact that we are still in a pandemic. And it's easy for us to spend the remainder of our time just talking about COVID. But we're going to try to talk about the initial phases and then really catapult towards recovery in the future. So looking at the first phase of COVID, which in my mind, January or March, depending on who you ask, of 2020 until about August of 2020. What were your initial concerns, either as a sector, for the sectors that you represent, or as an organization? What were the concerns that you had? And I'll piggyback a second question onto that. What were the partnerships or relationships that were game changers in how you address those concerns? Anyone can start.
I'll kick it off. I'll kind of amplify something you said in your introduction, which is the biggest concern I had was health equity. How are we going to reach the people who are hardest to reach and meet them where they are? this continues to be a struggle. We have a whole population in the country that is willing but unvaccinated because there still is access issues. That for me was kind of the moment where the camera panned into my face and I looked surprised and upset. And we still haven't really been able to find that equity internationally as well, where we're getting, we're only as strong as our most vaccinated population now, to borrow and modify a popular phrase, but we're still going to have new variants until we can find better ways to access people who need and want this vaccine. And then in addition to that, I would say recognizing how big this was going to get and the coordination mechanisms at the international level, at the national level, all the way down to local and sub-regional, they weren't built for something of this scale. Most of what we have built our emergency management frameworks on are acute, relatively smaller in scope compared to a global catastrophe, and they weren't built for this. And were they going to survive this event that was going to affect every single person on the planet? So those were my two concerns.
Yeah, I guess my first concern was probably around March of 2020 when members of Congress started coming out and saying, how much is this vaccine going to cost patients? Is it really going to be accessible? Thinking that you've completely missed the point. Since the Affordable Care Act, we provide vaccines to patients in this country without cost sharing. Now that's not true for every American, so we need to fill some gaps. But by and large, that was a non-issue, and I really felt like that was a distraction. Then we had, in April of 2020, the CDC sent a letter to the states and said, we're going to use the playbook from H1N1. We're ready to do this. We're ready to get these vaccines distributed and out to the states. And then you have the president of the United States saying, well, my generals. So, people were sort of asking, are we going to have a military response to this? Are we actually going to have the armed forces going out and administering these vaccines? So there was really a lot of confusion about how this was going to work. Ultimately, of course, what happened is we did rely on that CDC backbone, which I think was incredibly important. We did rely on state and local public health. Few states had the ability to distribute vaccines on this scale before the pandemic, but all states really did step up. And then we saw non-traditional vaccinators come in. At the beginning of the pandemic, we saw hospitals vaccinating people. That was incredibly important for frontline healthcare workers. And then as that wound down, they were trying to help get vaccines out into the community. So I think the public-private partnership there between health systems and public health was incredibly important. And then, of course, the retail pharmacy program. And I really was concerned at the beginning that we were going to overlook the role of pharmacists. They've played an increasingly critical role in administering vaccines, increasingly recognized as healthcare providers. And I was really glad when the retail pharmacy program got rolled out. We still, as of last summer, we weren't really making it that full last mile. There still were access issues, and part of that is because we, haven't really allowed physicians to order the way that they know how to do, and we do see a shortage of vaccines in physician offices, and so I think we have a ways to go to get through the end of this pandemic and for future pandemics.
Maybe I can just add on to that. I think this is not a challenge that was unique to CDC by any means, but at the beginning of the pandemic, when in some instances there was an opportunity for maybe scaling back or pausing some services that would come out of some types of organizations, those of us who were in public health preparedness had to figure out how to scale up and provide more services, more outreach, more support, more work, while also making sure that our workforce could continue doing that without the tools that we have now. So I think we're in a much different place in the pandemic now that we understand transmission so much better. We have such a high level of immunity from a combination of vaccines and infections in the population, and things have been able to kind of begin on that path towards recovery and return to normalcy. But we didn't know about any of that at the start. So really trying to manage an emergency and and continue to do so at the pace that we've had to work at for the full 2 years or so of the pandemic was definitely our biggest thing at the beginning. Being able, I think, to learn from partners who we already had and figure out, how are they doing things that was allowing them to transition to a new work posture, to keep their mission going, and to keep providing the services that their customers depended on, I think was also just a really good learning opportunity for us in government in general, being perhaps a little behind the times and a little slow to kind of uptake the remote work posture. But we were able, I think, to successfully figure out how to transition 12,000 or so staff to a remote posture and keep the public health emergency response going over the course of 2 weeks. What that means, I think, though, for the future, though, is that just when we're thinking about resiliency, we have to be ready for a true all hazards posture where we may not quite understand what's coming, and to be able to meet the mission, we have to be able to kind of pivot on a very tight turn radius there.
I'll chime in also. So thank you for the call outs for pharmacies as well as hospitals. We can't forget that they were the backbone to the emergency response at the beginning. And I'm sure we'll talk about it through resilience and the recovery as well. First concern was, could we get our arms on product? And, back in January and February, we realized, the reality of the fragility of, lean supply chains. And, we were already trying to figure out how to get our hands on more product. And it was really challenging. That continued for a long time. As it turned out, the pharmaceutical supply chain actually did quite well. It bent but did not break. And I've got to give a ton of credit to the manufacturers for adversity around challenges they were having, whether in the U.S. as well as other countries, in terms of continuing to manufacture, figuring out how to get product to the U.S. But the other thing that we learned sort of along the way was they had already moved significant product into the U.S. in advance, and so they were kind of ready to go as well. So that was our first concern. Then, when March came, what started was obviously the massive demand surge, and it was, some of it was real and some of it was the toilet paper effect. And that was, challenging for us because, we typically deal with the fact that there are shortages of particular drugs. We have to figure out how to put customers on allocation based on historic demand patterns. Well, guess what? Historic demand patterns have nothing to do with what was taking place during COVID. So we had to really adapt to thinking more broadly, and appreciate you bringing up health equity, thinking about all of the different factors that we needed to put into allocation formulas and ensure that we were really getting product to where product needed to be. We were fortunate that, from the standpoint of where we sat, that it didn't hit everywhere all at once. It was local in different places, so we were able to modify those allocation formulas. We were then inundated with requests from different government bodies for data in terms of what's happening. We didn't know who was, calling the shots at that point. Lots of different people were asking for different data, and we realized, sort of back to your thing about concerns, the lack of understanding about how the commercial supply chain works. And, that's kind of a key message around, and I think that's been talked about a lot here, which is understanding how the crisis management and the public health sector works versus the commercial supply chain. There's, and we continue to work on it, and we want to make sure that doesn't get lost. But want to really give Healthcare Ready a great shout out for being sort of an intermediary who helped mobilize the commercial sector to work with government officials and sort of, lead to what ultimately was the supply chain control tower, which is data that multiple parties, competitors, are able to share into the government and create that efficiency. But even once that was built, and a lot of things that had to take place was, back to what I'm saying about differences with how government works versus the private sector, just definitions. What are the definition? What's the definition of a shortage? Things as basic as that we had to work through. So, those were some of the things that, we really, stood up quite well over time. And I'll close with your, what you stated. We were sitting there wondering, we saw that it looked promising that the vaccines were coming by the summer of 2020. It wasn't clear to us how the distribution was going to take place either. So we were equally anxious about the vaccines were going to get there before the distribution plan. And that was our last concern in the summer of those 6 months.
I'm getting anxiety just thinking back on all of the things that you guys just noted, but no. So I think as you all highlighted partnerships and key partners, as you've highlighted a lot of the issues that were circulating and still persist in some ways, as we think about shifting into that nebulous idea of recovery. And eventually getting into a space of recovering from COVID amidst a lot of other things going on. We are recognizing the true impact that this pandemic has had at the community level, at the healthcare system level, with our pharmacists, as you know, many of you have noted, have stepped up in incredible ways. There have been tremendous impacts on just health and well-being. As we're thinking about that recovery, we also know that we will need to continue to prepare for other events at the same time. So what do you see as the challenges for us transitioning into an effective recovery? What does that look like from your vantage points? And what would we need to have in place in the way of partnerships, relationships, investments, capabilities that would allow for us to do that? Again, anyone can start.
Happy to start here. So I think that the notion of recovery probably has to start looking a lot different for all of us than perhaps what we may have historically thought about recovery looking like. From my view at CDC, we are still managing 6 concurrent public health emergencies at the moment. So, COVID is on everyone's mind, and we only have one EOC, but in support of our centers, we are responding to monkeypox. We have been continuously responding to cases of polio worldwide since about 2011, so there's not been a day since 2011 that the EOC was not activated in support of that. There are hepatitis cases going on in children. There's a regional response to support planning for recovery in Ukraine whenever that conflict ends, and a couple of other things the agency is paying particular attention to. So it's never not a response mode for us. I think through the course of all of those, one particularly interesting thread that maybe I'll just mention is the communications response. So, we do a lot of resource coordination and information coordination, and everyone has seen really through the course of the pandemic the misinformation and disinformation that has been a challenge probably in all sectors, but especially in public health, and just trying to make sure that people have the information they need to make informed decisions about how to protect themselves from whatever the public health threats are. And I think that building up partnerships for getting out good, correct, reliable, unbiased information that people can get from a source that they themselves personally trust, whether it's from government or from a particular private partner who they can put their reliance in and take that information and do with it what they will to make the right decisions for their own health and to protect the health and resiliency of communities. It's just going to continue to be particularly important because of that changing landscape of emergency preparedness and response, and both the complexity and the continuing kind of overlapping number of public health threats that we're dealing with all the time.
I'm happy to share some thoughts and piggyback on that. So, I believe that vaccines and therapeutics for COVID-19, obviously we're not done with this response, and they need to continue to be very accessible to patients. But we need to really tweak how we're delivering those, how we're distributing those products. So to his point, public health it's chronically underfunded, it's incredibly strained, and state and local public health, they're on the front lines of responding to all of those outbreaks. And because of the COVID-19 response, they haven't been able to give as much attention to routine vaccination, which is leading to some of these outbreaks, and that's going to continue to be a problem. So having them continue to bear this responsibility of distributing vaccines, coordinating the distribution of therapeutics, although AmerisourceBergen's doing a great job of distributing a lot of those therapeutics, we need to take some of the load off of state and local public health and involve traditional private actors who have the know-how and can help. And that doesn't mean that we should immediately move into a commercial market. We need a phased, planned transition. So today, all of these products are still procured by the federal government. We have vaccines that have EUAs and full approval. We have therapeutics that have both. So what we need to do is start to really try to rely on additional channels to make these things accessible in settings where they're not accessible, and again, to alleviate the strain on public health. And then ultimately, we need a very planned, thoughtful roadmap to transitioning to a traditional public-private marketplace for these products that keeps them accessible. And today, there is no guidance on how that transition is going to work from the White House, from CMS, from CDC. That guidance doesn't exist, and we need that roadmap. I would also say, as I talked about the gaps and the fragmentation before the pandemic, that problem still exists. And absent the government procuring all vaccines for every single American and providing them the way that we have during the pandemic, we're going to need to fix those gaps in vaccine coverage. And so the president's 2023 budget proposes the creation of a vaccine safety net to close some of those gaps and to create infrastructure for adult vaccination. So we have a great example in the Vaccines for Children program where we've really built that infrastructure across pediatric practices in this country. But we need to really extend that into the 18-plus population. We need to make sure that more providers are equipped to vaccinate. But if public health is expected to onboard and enroll those providers and support them in their practices in vaccinating, they're going to need resources. So it's very important that we think about the public health resources that are needed and the potential safety net reform that's needed as we move ahead.
Any other thoughts?
I'll jump in. Oh, do you want to go?
No, go ahead.
All right. Thank you. Always we're looking at this through the lens of health equity, which I always appreciate, and I'm really excited by the emphasis on health equity from private sector, which I think is really coming to the forefront, and it's going to change how we do our recovery. There's a couple other, I think, things to consider when we enter into the recovery period. One is, thank you for starting by saying we're still in a pandemic, because I don't know if that's known in a lot of circles. Probably this room, you got it, but we're still in the thick of this. And we have to do recovery at the same time we're doing response, at the same time we're preparing and building resiliency for the next one. And that investment couldn't start too soon. If that started in January 2020, this year would look a lot different. And so we've got to walk and chew gum at the same time to make sure that we're in a good shape addressing what is going on now. As you say, 6 concurrent and compounding disease outbreaks in addition to our natural disasters. So we've got to have concurrent conversations about this. The other thing I would say is, if we look at the period after 9/11 and we saw how focused the country was and the world was on making sure that something like that never happened again, and we saw the 9/11 Commission get published, we need a nonpartisan after-action report yesterday that tells us, gives us a pathway forward for this and understands what happened and how we can mitigate this in the future. Thank you.
I guess what I would say is that there are public-private partnerships that began during the crisis that should be continued. So I'd call out the role of pharmacy as one. That pharmacies have really stepped up, and we've recognized they can do more. There are things that should probably dissipate, as you were mentioning, around bringing the efficiency of the commercial supply chain back into play. And then the third category is, as you're pointing out, things that are in the 100-day plan or the 1-year plan around, what should be done. Where are the new partnerships that need to be put in place that aren't in place today? And I think the plan does call out things specific to, such as vendor managed inventory, support from the commercial sector in government programs. So I think this idea of 3 different types of pathways we should go, but obviously it almost goes without saying. Some of the things we set up in terms of communication channels, understanding channels, have to be maintained, because if we stop talking to each other as this dissipates, it's going to be lost within a matter of months, and all of the progress in terms of understanding how the government works, how the private sector works, it will be lost, and we've got to maintain that no matter what.
No, I think that's a really important point. I think you all have raised the difference between seeing the needs of the community and being able to identify which partnerships, which mechanisms need to be in place. Chris's point about the dynamism of this moment, recognizing that the days of a single response to a single event are long behind us. And so it does call on us to make sure that we are bringing every capability we have to bear, and those communication channels, and thinking about what the parameters are of those relationships and how to make sure that we are continuing to coordinate, that the communication is happening between events. But how do we leverage all of the capabilities that can be brought to bear? And so oftentimes when we talk about the private sector, I know, many versions of this conference, maybe 5 or 6 years ago, we were breaking down the idea that every partnership with the private sector meant a contract. And I think COVID really allowed us to see that there is a lot more in the way of partnerships than just thinking about that single transactional relationship. So recognizing that we are almost at time, I just want to ask one final question to each of you. What gives you hope for our path forward?
Start. I think all of the lessons that we've learned from COVID, as terrible as the pandemic has been, it has given us an opportunity to test systems that we had been trying to build up and put in place for years and years, and we've had the opportunity to see what worked well and what didn't. And I think that's a critical part of our kind of cycle of emergency planning, test, training, and exercise, preparing for the next event. So we know where we need to focus in trying to rebuild. We have the opportunity to fix some critical gaps ahead of whatever the next major public health emergency is, so that we're in a better spot the next time something big rolls around.
I'll add to that excuse me, as you mentioned, the supply chain bent, but it didn't break. And there is some recognition now where the vulnerabilities in the supply chain are. Supply chain itself has become a very common term in the U.S., and so people are aware and will be advocating for it. Jack White, the guitarist, is having a supply chain tour right now, and I think he's coming to the Baltimore area. I don't work for him. But I think it's brought this public health lens that I think is really critical for the new challenges we face as a country, as a global entity. And I think it also has left us with better communication pathways between the public and private sector. I think there's more touch points. I think what we need to do moving forward is make sure the touch points are very intentional. We don't get partnership fatigue, and we're making sure that we're staying with a battle rhythm that makes sense for the context that we're in at the moment.
Yeah, just to probably repeat some of the things that have already been said. I mean, the key words that come to mind for me are nimbleness and adaptability. We don't know what the next crisis is going to be, but for us to be able to operate together in an adaptable fashion is something that I think we did figure out, fairly significantly during this crisis.
They say don't waste a crisis, and all things in health policy are truly incremental, and I think we've seen a lot of great incremental strides. Congress just passed a bill extending the expansion of telehealth coverage, which I think is a fantastic thing. We see the FDA further acknowledging the role of the pharmacist, which I think is a great thing. We've sped we've seen new possibilities in the speed of vaccine development and approval. So I could go on and on my list, but I think that gives me a lot of hope.
Please join me in thanking the panel for their thoughtful remarks.